I think we could probably do that now. Right. So welcome everyone. So my name's Daniel Davidson. I'm one of the program directors at CIRA. I think almost everyone, if not everyone on the call is familiar with CIRA, but for the sake of the recording, I will say we are the Center for Interdisciplinary Research on AIDS based in the Yale School of Public Health, and we're funded by the National Institute of Mental Health. We support HIV science at Yale and beyond, including internationally. One of the things CIRA is known for, and our affiliated researchers pretty consistently tell us they find valuable, is our work to support community engaged research. One of the ways we do that is through a community advisory board made up of people working in HIV/AIDS and in the nonprofit and government spaces, and overlapping with people who are personally impacted by HIV. One of our longtime CAB members was Shawn who, if you spent any time in Connecticut really before she passed away, you're probably familiar with Shawn's work. Her name was synonymous with HIV advocacy, and she was an important bridge between research and community practice and policy. So when CIRA was looking to set up a student fellowship program, which we did about 4 years ago, we did that in Shawn's name. We've now had several years of students placed at Connecticut organizations doing HIV-related work over the summer. And we've been able to financially support the students and their placement sites with some help from the Heaney Fellowship, which is intended to support student research in HIV at YSPH. So today we're joined by our summer 2025 fellows who are based at the Yale Community Healthcare Van, and you will get a sense of the work that they do through the student presentations, so I won't take up time explaining that. So we'll have Shawn Becker and Soha Kosa present on their summer projects, and then ideally we'll have a little bit of time at the end for some discussion with CIRA's director, Trace Kershaw, and Natalie Kill, who is Associate Director of Domestic Projects for Yale Clinical and Community Research, who was the preceptor at Community Healthcare Van. So let's get going, and we'll start with Soha Kosa, who is a second-year Master of Public Health candidate in Social and Behavioral Sciences, and her work focuses on substance use treatment, digital health communication, and the structural and social factors influencing the health of people who use drugs. So Soha, if you want to pull your slides up, and then you can take it away.
Thank you, Daniel, for the introduction. I will just get started. Okay, hoping everyone can see my screen. So like Daniel mentioned today, I'm going to be talking about harm reduction in the greater scheme of anticipated, enacted, and internalized stigma within the harm reduction setting at our storefront and the community healthcare van. So a little bit about this is sort of like a table of content about what I will be getting into today. I will be talking about the harm reduction services through the research work, like I mentioned in the three domains of different types of stigma, by doing a lot of data analysis work on that, and intertwined with the social media aspect of it to be creating destigmatizing campaigns and information that can increase engagement with our vulnerable population and improve the visibility of harm reduction resources for the people who use drugs within New Haven. So, and also I will be talking about some of the supported program operations and outreach, like the resource guides created, the metric dashboards, content calendars that span all the way from January to December about observances, awarenesses, and campaigns that we can include in our social media. So a little bit about the background. I think it's really important to talk about the background and the statistics of stigma and how that plays a massive role, especially since I do have a track in implementation science. This is something that is really important to me. So more broadly, stigma is a social process which leads to creating stereotypes and assigning labels to those that are considered to deviate from the norm or to behave quote unquote badly. It creates social conditions that make people who use drug believe that they are not deserving of being treated with dignity and respect. And this further perpetuates fear and isolation. And so in 2022, which is one of the more recent years I could find on data, nearly 49 million people, spanning all the way from age 12 to older adulthood, report a presence of substance use disorder in the past year. This is by the CDC. So putting that in the context of Connecticut, about in 2023, for Connecticut age adjusted rate for unintentional drug-induced mortality was 33.3 per 100,000 compared to the national average, which is much lower at 29.1. So this is just a fact that I found, which is that in Connecticut, residents are more likely to die of unintentional drug overdose than of a motor vehicle accident. And this is the overdose graph that is basically specific to the Connecticut area. And as we can see, there is a very staggering, for the community that we serve at least, a very high overdose rate. And they also are linked with financial insecurity, that they do not trust their neighbors in the area that they're from, and that they have poor general health, overall health. So, given the overdose rate by zip codes here, which is from 2020 to 2023, we see that there is an importance of conducting a pilot study, which is what we did this summer, that yields insights about the different forms of stigma. So that we can optimize the way that we approach people who use drugs so that they can feel supported and respected in every capacity. So this is the current pilot that I was talking about that I worked on this summer, which is the main overall question that we had. And the way the data was gathered was to answer the question of how does stigma differ between medical providers and syringe service program between the staff and how that affects service acceptability. This question did take a lot of turns eventually. I'll get into that. But this was the first question that we started with. And this is on the basis that which the data was collected. And I want to dive more deeper into the different types of stigma that I have been mentioning and what those mean in this context, at least. So, anticipated stigma here, when we're talking about it, it basically means the fear of being judged or discriminated against, and that discourages people who use drugs from seeking services. That can be services at our storefront location or even services at our vending machines that we have for patients. And then enacted stigma, which is the direct negative treatment from staff, which creates a mistrust. Internalized stigma is shame that reduces self-efficacy and willingness to engage in care. And this could be either current shame that they hold or maybe future shame that they anticipate that they would have. So about the scale that we used, it is a adapted stigma scale from a previous study that was done, but the MPS-PWUD, which is medical provider stigma experienced by people who use drugs. And this was used in a similar data set, much larger data set at least, of people who inject in New York City by Fong. And it's a Likert type scale that covers items, a wide variety of items pertaining to respect, treatment, dignity, fear of judgment, willingness to disclose drug use, and provider trust. So the scale used in my pilot is just an adapted version that breaks down similar items into the three forms of stigma, like I mentioned. And it captures stigma as experienced directly by the patients, making it distinct from other provider attitude scales. Going into the data now. So we did not have a massive data set. This is data that had been collected from a previous year that I had was fortunate enough to work on this summer. And after cleaning the data, we had 52 valid responses. Initially, it was about 70. So that was quite a bit of a drop. And the survey sections, like I will get into, covered general satisfaction that people had, syringe services and the stigma related that they feel towards that. Medical stigma as well was covered in here, and demographic factors. So in terms of their age, their race, sexual orientation, housing status, all that was covered. So how we cleaned up the data, basically, we removed all the tests and incomplete responses that were there. We also reverse coded negatively worded items so that we could have data that is consistent and easy to work with. We created composite stigma source for each domain and then conducted statistical analyses on those. So after cleaning it up, this is what our table one looked like essentially, which covered all the important information we needed to see what we were working with. Like I mentioned, it was a sample size of 52. And as you can see here, the minimum age was 29 years old and the maximum age was 72 of the respondents, with the median being 45.3. Mean overdoses in the past 12 months was 1.6. And we have some very important factors here. Like we can see that for housing status, unstably housed were about 8 people. declined to answer were 5. Literally homeless was another very key feature, which were we had 26 of the 52 were literally homeless people. And stably housed were about 13. Our population was majority white and multi-race. We had 5, Black African American about 6. We also had a highly male study sample. And as we can see in the last two questions, ever received syringe services, 90% of the people that took this survey had received at some point syringe services. And when we were broken down by ever received medical services within our storefront, about 65% of people had received medical services. So in terms of participant demographics, I believe I went over this just now. We have a massive majority that have used our services before for syringes. 65% have used medical services. And what I mean by that, they have received screenings, case management. Our age range is from 29 all the way to 72, majority white and male population. So this is the study that we drew our inspiration from, which is medical provider stigma experienced by people who use drug, and people who inject, at least in New York City. This is the table that they had created, which looks a little closer up like this. It was broken up by the percentages of responses, and like I mentioned, a Likert type scale, which is what we had for our paper. And this is our paper, actually, the pilot study that we conducted. We have initial survey questions, which is just like I was seen at a reasonable time, um, and I was treated with respect. As you can see, most of the majority were either in the agree or strongly disagree, with very few choosing to not answer the responses or the questions. Our questions were broken up by received, as you can see in table 2, by received syringe services and received medical services. So like you can see here for syringe services is while receiving SSP services, I felt respected and valued regardless of my drug use. 72% said strongly agree versus 21% said agree. Again, very few people. And like we can see when we reverse code the questions, for example, when we go to question 4, when I go for SSP services, I feel as though I tried to hide my drug use. Strongly disagree was about 46% versus disagree was 23%. So we know that patients are following through with the way that we're phrasing the questions. And this is similar. Another thing I found very interesting that we pivoted on later on to do is, as you can see this in the last part, which is question number 22, I prefer using mobile locations, community healthcare van, delivery, vending machines for medical services to avoid stigma. This is not just for medical services. This was also a question we had for the syringe services. We did choose to omit this because we had an even split amongst all the responses, both for syringe and for the medical services. So in terms of data analysis, we did quite a lot of extensive data analysis to see what we can make from the data, and especially because the data set was much smaller than anticipated. We conducted a normality test, so a KS and Shapiro-Wilk test, which is basically used to determine if the data set is normally distributed. And Shapiro-Wilk test specifically is more powerful in smaller sample sizes, so that seemed more appropriate. However, we did find that the data was not normally distributed. And so we conducted a non-normal distribution test, which is the Kruskal-Wallis H test, which just compares the medians between 3 independent groups. And we wanted to see if there was any statistically significant difference between anticipated, internalized, and enacted. And we did see quite good results in that case. Anticipated stigma was about 2.2, and that was the median for it, versus enacted stigma, which had the lowest at 1.6. This is just a little bit more of the SPSS data that was brought forward, and it does show a clear hierarchy in stigma experiences amongst syringe users. Enacted stigma, like I said, has the lowest, anticipated the highest, suggesting that participants' expectation, and if you go back to the definition that I shared earlier, this just means that participants' expectation of discrimination, whether future or current, are more pronounced than their actual experiences of stigma. So this is independent of provider stigma, but rather their own self-efficacy and how they view themselves in terms of being stigmatized when they show up at the clinic or interact with someone that provides them care. This is the box plot that I had created that also shows a visual representation of these numbers I'm sharing. And like I said, anticipated does have a higher level of stigma. Then going on to seeing each question specifically to see the inter-rater reliability, because this is kind of in a ever-changing field where we do not have a proper validated scale from my literature review and also the studies that I had previously seen. We do see a lot of values where we're finding questions, we're getting answers, but we do not know what those numbers translate to. So it's really important for me to look at item level descriptive statistics to see the inter-rater reliability of each of the questions. So I conducted Cronbach alpha testing to assess the internal consistency of the questions, and anything over 0.6 would have been generally a good score. As you can see from this table, at least, overall stigma, when you combine all the questions, does give a pretty good value of 0.827. But when you look at the questions independently, just because of the number of items present, the consistency isn't very great because we can't gauge a lot from the questions that we have. So this would be really interesting to conduct another pilot, possibly a further study that assesses more questions and has a greater participant pool. However, like I mentioned earlier, housing was something that we had received amazing results at. Almost everyone technically answered the question. And we also had a overwhelming majority where a lot of people were literally homeless. And so I went into seeing how each of the questions were answered by people that had answered that they were literally homeless. And that gave really interesting results. This table is quite hard to read, but I have broken them down by these as the most important findings. Um, so how we were looking at it previously, where anticipated was a higher level, here internalized stigma was higher. That's interesting because it had a p-value of 0.033, and they had the highest level seen among participants who declined to report their housing. We did have a few people that did decline, so which suggests greater shame, fear, and mistrust possibly. And the people who answered declined to answer reported reduced willingness to discuss their drug use and greater concern about disclosure harming their care. Enacted again remained low consistently, reinforcing that participants generally felt respected and safe with SSP staff, regardless of their housing status. And those who said that they experienced anticipated stigma, they were also consistent throughout. Yeah, but like I mentioned, preference for mobile services, we didn't look at that very well. We chose to omit it, but they did have, they were pretty satisfied overall, also with their housing status. And this is just an example or a visual representation of the internalized stigma that shows people who declined to answer had higher levels of internalized stigma, surprisingly. Um, so these are some key takeaways for this part. Which was number one, we have strong engagement from a very highly vulnerable clients. Since 50% of the respondents were literally homeless, and the sample included also a high overdose level, at least once in the past 12 months for people, it suggests that there's a high feasibility of the data collection, that they were willing to participate with us and answer our questions. We had high SSP satisfaction levels. Overall, 73%, this is a value that we did get out of data collection, where 73% of respondents reported being satisfied with the services that they are receiving, which suggests that the SSP may function as a buffer against broader structural discrimination. There was a strong acceptability despite demographic concentration. Although our population was mainly white and male, there were people that had differing sexual orientation or multi-race, but the results were pretty consistent throughout when they were tested individually. This also suggests a very important need for conducting a larger follow-up study. And anticipated stigma values remain relatively high. So despite low enacted stigma, clients still expect that they would feel discriminated. So this suggests that there should be some studies done on broader structural and systems level that SSP cannot control itself. But this also brings me to my second topic of the power of social media. I worked a lot and heavily with social media this summer. I was really happy to do that. And it's just a mean and a platform where we can leverage social media to make it a tool where we can reduce misinformation, build trust within the community, and provide a level of care that extends beyond just the clinic and even the mobile locations. So why social media? More generally, the basic things like reach and accessibility. You can reach so many people with social media. Breaks down geographical locations. Um, Engagement, it provides two-way engagement where people can ask questions, they can comment, share, creates peer-to-peer learning. Education and awareness, like I said, I had created a huge pamphlet of observances, events that in the sphere of harm reduction we can post on and create a broader community where people rely on us for getting more information or clearing up misinformation. And obviously, it's low cost. It doesn't really cost anything to post up something on social media, Facebook. And a single post can reach hundreds and thousands of people, especially if it's shared. So I'm going to go into a little bit of what I did this summer with social media. This is content that I had created and posted on our social media page, which is Fact Check Friday, for example, where I would provide something like here, syringe service programs are a new idea that encourage drug use, and go into detail about it. And so this is something that's so simple, but it also helps. It helps create a narrative that we are here to help, and this is not just something that we can provide face to face, but are also available online. It's also something that I think is really interesting because whenever I would work at the storefront, I had many people ask me about the bus schedule and the hour schedule for the vending machines and stuff and locations. And so it's interesting to have those also up there for people if they can access. Um, like I said, awareness and holidays. There were quite a few awarenesses and holidays that passed this summer that I had was fortunate enough to create for World Hepatitis Day, Zero HIV Stigma Day, which did end up getting printed and posted out on our storefront, where people can have a QR code to link it back to our storefront's Instagram page. And it did help significantly, actually. So I did do a lot of analysis into how the reach and consistent posting helped. And I tracked it by three different categories, which is views, interactions, and followers. As you can see here, the first one about the views had reached 3,664 in the last 90 days. This is a screenshot from after my summer internship. Previously, views were about 50 to 100. Interactions went to 63, which ended up going to, which was previously at 15. And the followers had a 17% increase and reached up to 158. So key takeaways from that is that social media expands the reach for highly vulnerable clients. I know that it's not very feasible. Not everyone has access to it, but for those that do have access to it, we can also be posting them on our storefront so that people have access to it. I know Facebook is something that people enjoy using, so we could also possibly leverage that. Educational content also reduces anticipated stigma because creates the feeling that they are not in this alone. There are people there, people that can share their stories, people that they can learn from. And consistent posting also builds trust and reinforces acceptability. They shouldn't feel like they're in this alone. They should feel like they have a community that supports them. And just creating something like that helps extend that same sense of safety and reliability into these digital spaces. And metrics demonstrate growing engagement and community connection. So just these numbers alone also show that people are engaging with it, people are interested in seeing it, which shows that there is a demand for it. Lastly, social media support system level stigma reduction by amplifying positive narratives, sharing harm reduction holidays. The community healthcare van online present helps counter structural discrimination, at least to some extent. And so we can align that with the pilot's findings that we have to make sure that the SSP serves as a buffer against the broader stigma. And we can do that by, as I'm going into it, the future plans that I have, hopefully, which is extending the stigma assessment. We did cover a lot of interesting questions and prompts in the previous pilot, but it would be really nice to see more of that and possibly how we can get our clients involved with us. So basically creating launching a mixed method study where we include the client's social media use, their platform preferences, and basically meeting them where they are at so that they can feel safer engaging with us. We can include items like syringe returns, an incentive to return those syringes. And this is the example of what I have. It's kind of in the works, but a pilot study questionnaire of how we can get people to interact with us on social media and counter the stigma that they feel, especially since we saw that anticipated stigma where they feel like they would be discriminated against internally is affecting a little bit of the responses. So it'd be nice to know what type of platforms they prefer, what would they like to see, what's the best way to contact them, and also creating a way where they can feel like we're in this together with them. And so creating probably like raffle entries where they get tickets and they win prizes that are important for them, like a gift card to Dunkin' or a hygiene self-care kit or seasonal items like especially in this winter, hoodies or blankets that could help them. So yeah, that's all I have. Thank you.
Thanks, Soha. All right, why don't we do Shawn's presentation and then we'll kind of save time at the end for discussion. So Shawn, if you want to get your slides up. Shawn Becker is also a second year MPH student in SBS, and his work and research interests are related to substance use treatment and harm reduction services.
Yes, hi, hello. My name is Shawn Becker, and then today I'm going to talk a bit about the initiatives that we did over the summer at the CHCV. Primarily, my focus was on quality improvement initiatives surrounding the various aspects they have currently, including their vending machine program, their syringe pickup program, and their storefront transactions. So just a summary. First, I'm going to talk about sort of just general logistics about the internship and the various components that went into that, and then talk about the vending machine, syringe, and front desk transaction data. Yeah, so just a little bit about the internship. I was honored to serve as the Shawn Lang Legacy HIV Health Equity and Social Justice Fellow this past summer with the Community Healthcare Van through the CIRA Lab. And this was a very great opportunity for me to serve in a community organization. And some of the highlights were assisting with general analyses on the various programs run by the Community Healthcare Van. That was a big help and a big eye-opening experience to have to be able to help with that. And then just some other aspects of the internship that maybe were not touched upon later in my presentation, but we participated in weekly discussion sections with other health equity fellows throughout the duration of the summer. And this was a wonderful opportunity to connect with other health equity fellows at the Yale School of Public Health. And they were led by Jason Martinez, who's on the call now. And they were really great to reflect on things such as biases, such as racism, institutional racism, where you see yourself in the community and how things work. And it was really eye-opening to hear the experiences of other fellows within the New Haven community, as well as to give feedback on how my experiences helped with that. And then in addition to sort of some of the data work that we did over the summer, we worked kind of as a team member, interfacing directly with clients at the storefront, providing local mobile outreach on the van, restocking harm reduction vending machines, and attending meetings pertinent to public health at the local and state level. So this past summer, we were really able to be involved heavily within the clinical operations to see how things are run on a day-to-day basis and to be involved within the community. So I thought that was a very wonderful opportunity. So then just a little bit more about the program. Currently, the Community Healthcare Van, they had a wealth of data related to the various programs and the systems that they had. For starters, there's Click Fix and staff syringe pickups. This was internal tracking of when they would go out to pick syringes up from around the city and around the local area. And then their front desk transactions, their front desk transactions were recorded on E2CT Prevention, which is a statewide website for harm reduction in Connecticut. And then their vending machine programs, this is run through IQ Tech and also implemented in that website as well. And then here's just an example of one of the vending machines we have. This is one of the vending machines at the Apt Foundation in West Haven that I'll talk about later on. So first, one of my primary focuses this summer was looking at their vending machine program. And currently, the community healthcare van has two vending machines set up, and they're maintained by the community healthcare van at different locations throughout the New Haven area. They have a vending machine at AP&H, which is a place to nourish your health, sort of downtown, and this began service on February 17th, 2024. This vending machine has 24/7 access, so individuals and clients can come up and receive supplies whenever, even if the location is closed or on the weekends. As well, they have a second vending machine at Apt Foundation in West Haven. This began service on August 26, 2024. And these hours are from 5 a.m. to 1 p.m., Monday through Saturday. And the current plan is to add a third location, preferably in the Fairhaven neighborhood. And these vending machines really help expand the reach of the van. In particular, one of their strengths is being able to provide supplies and services outside of normal business hours. And as you can see, the vending machine programs are still relatively new, beginning only last year in 2024. And these are some of I believe they're the only two vending machines in the entire state of Connecticut. So this summer, I looked at some preliminary data and then to see how kind of they were doing in that regard. So then all my data analysis was through middle of June. There have been a total of 7,400 transactions split between the vending machines. And then just a quick breakdown at AP&H, there are 75 unique individuals that made up all of the transactions. We see that about 32% of all transactions took place on Saturday or Sunday, and that the successful rate of vends was about 93%. And this is sort of the success rate when people come to the vending machine and then it actually dispenses items, because there are limits to what you can receive per week. At the Apt Foundation, a total of 97 unique individuals made up all transactions. We see about 16.4% happened on Saturday, as the vending machine at the Apt Foundation is closed on Sunday because it's inside the clinic. And again, we see similar success rates at about 93% of all vends. And then here's just some summary of the items we have in the vending machines. So we provide syringe kits, both 0.5 milligrams and 1.0 milligrams. And these are similar to the ones we give out at the storefront. They have items such as syringes, tourniquets, cookers, cottons, and Band-Aids. We also have hygiene kits, Narcan, safe sex kits, which include things like condoms and lubricant, sharps containers, and wound care kits as well. And this is sort of the breakdown of successful items dispensed. And then, so a big idea of the vending machines is that we're able to expand their reach. So just in general, of all the vending machines we have so far, we see about 61% of all of these vends are outside our normal business hours at the community healthcare van, which is typical business hours, Monday through Friday, 9 to 4 p.m. So we're really seeing a lot of usage outside of traditional hours, which is good for us in terms of reaching out clients that we otherwise may not. So then just a little bit more about the AP&H vending machine. So here's kind of a graph showing the different items and then how they were dispensed on a monthly basis from their start. We see that at the beginning, there was relatively little interest in the machine, maybe due to this still being a relatively novel concept and clients not being aware. But we see as it progressed through the summer and through the fall of last year, we really started to see more items being dispensed. And the two most popular items dispensed at the vending machines are the syringe kits with the needles in them. And then we also see hygiene and Narcan being very popular as well. And then, so at AP&H, we see that 81.6% of all vends were outside of our normal business hours. So we're able to reach a lot of people that we otherwise would not have at hours we otherwise would not have at this location specifically. And then here's just kind of a distribution of how it goes through the week. We see a lot of vends happening on Sundays and then sort of stable throughout the week on the weekday. And then here at the Apt Foundation, this has been in service a bit less than the AP&H one. And we see again at the start, very little upkeep, but then or uptick in usage, but then as it sort of becomes people become more aware of it, we see more items being dispensed and so forth. Again, we also see that the syringe kits are two of the most popular items here as well. And for this vending machine, this vending machine, we see a bit less usage outside of business hours, simply because the Apps Foundation is open for a good portion of our business hours. But clients can come sort of before in the mornings, and we also do see a decent high utilization, about 44.8% of transactions occurring outside of business hours, including on Saturday as well at this location. And then we see sort of higher frequency in the beginning of the week and then trails off a bit, and then more upkeep on Saturday. Some key takeaways from the vending machine program were a large percentage of uses outside of traditional hours and days, clients having access to supplies 24/7 at the AP&H vending machine. And then future opportunities data supports the need for a third vending machine, and that a third vending machine could be successful. Again, shows potential to reach clients outside of business hours. Excuse me. And then we also give out a large proportion of hygiene kits, about 11% of all transactions, yet these are not recorded in E2CT. So syringe pickups, these are a map of the syringe pickups in and around New Haven. And this is sort of another major area that the community healthcare van operates on. They go out to the community, whether that's if they get notification from other organizations to come out and they have used needles somewhere, they will go out and collect them, or they will also sort of do kind of sweeps around the local area, particularly in the Hill neighborhood as well. And this is kind of just showing the general distribution of those syringes. We see also these little tree icons here. These are locations of syringe drop-off oak trees, which are these sort of metal, like purple trees where people can go and drop needles off as well. And the community healthcare van also goes to these locations and collects those. So here is a distribution kind of throughout the area of those syringes from December 13th, 2023 through mid-June 2025. And we see that primarily a large percentage of these syringes are collected in this zip code, the 06519, which is where the community healthcare van is located. But we also see a fair amount of pickup in this sort of 06511 zip code, as well as pickup in the 06513 zip code as well. So these are sort of just the general zip codes of New Haven. And then just a breakdown percentage of those syringe collections. We see about 56% are being collected in the 06519 zip code, and primarily making up.
Can I interrupt one sec? Can you just clarify when you're talking about pickups? So you said that there are pickup sites that are these trees, but the rest of the pickups, can you clarify what that means?
Yeah, of course. So these pickup, so the pickups can come from a variety of different options here. They could be whether staff goes out into the local community and sees them, or if people report them as well. And that's sort of either like active or passive pickup throughout the city. Is that kind of?
Yeah, I think so. So it's like picking them up off the street, is that what you're talking about?
Mm.
Syringe
Yes,
litter.
yes.
Yeah, okay, that's what I thought. Thanks.
And then, so there's a couple different formats that they use for this reporting, but the primary formats are See, Click, Fix, which is this SCF right here. And this is run through the city of New Haven. They have partnerships with the city where people will report if they see used syringes, and that the staff will come out and then go collect them, and then collect any other litter that may be in the area as well. And we also see most of the trips, however, happen just from staff going out or from in indirect seeing of these syringes. So then some key takeaways of the syringe pickup analysis was that there's a strong collection presence in the Hill, downtown, and in Fairhaven. We do see that the see-click-fix reporting is a crucial component, with the majority of reports being able to be completed. Of those see-click-fix reports, we see about 75% of trips where they do collect at least one needle. So these are a good presence in the city where they can go and actually find the litter as well. And then some potential future opportunities are expansion of services into the New Hallville, Westville, Dixwell, and Fairhaven Heights neighborhoods, as currently rates in these areas are low. And then it highlights syringe usage in Fairhaven that is present and further demonstrates need for services such as vending machines in the areas potentially as well, or sites where people can drop off needles. And then finally, my last sort of main focus for the internship was on front desk transactions. So at a glance, from January 1st, 2024 to June 25th, 2025, there was a total of about 8,000 transactions to 937 unique clients. The average age of these clients was approximately 45 years old. And the total number of units dispensed was 735,457 units. And units in this case refers to any individual item that is given out at the front desk. So that would include things such as one cooker potentially, or one tourniquet put count as a unit. And then of syringes, we give out we've dispensed just under 400,000 total syringes from this time period, where we see a slight preference for larger syringes, which are bigs, the 1.0 milliliter ones, compared to the smaller syringes. And then in this same time period, we've received about 312,753 syringes from clients. Again, we see higher return rates from the bigs. So this return rate is just under 80% for syringes at this time period. And then here's just sort of a graph of the various items that we give out per month from January 2024, broken down by item. So all of these items are given out at the front desk storefront, includes alcohol pads, antibiotic ointments, baggies, Band-Aids, big syringes, cookers, cotton filters, female and male condoms, fentanyl test strips, lip savers, which are sort of mouthpieces for smoking kits, sterile waters, tourniquets, vitamin C, and various things of these nature. So these are all sort of harm reduction items. So people come in, they request, and then we dispense on an as needed basis. And then sort of just to show a little bit about the geographic distribution, these are the home zip codes at intake from the various clients that have come to the community healthcare van storefronts from this time period. So we see a wide range all over Connecticut, primarily focused around New Haven, which is right here. But we still see outreach and clients coming from various different zip codes as well. And then just to kind of go further into New Haven here, we see a large number of our clients do come from the Hill and downtown and 06511 zip codes. But we still see a fairly high amount of clients coming from neighboring zip codes as well in New Haven. And then another proportion of clients come in to our storefront that select only for smoking kits. And these are interesting because they do not come in for sort of any other resources, such as clean needles or other supplies that kind of only select for smoking kits. So this is a population that the community healthcare van is interested in targeting more and understanding a bit better. So I did some very preliminary work around this area, and we see that about 11% of clients that have come in during this time period have only got smoke kits from the front desk, which represents about 334 different individual transactions with an average age of about 47 years old. So then some key takeaways from the storefront analysis. It could provide SSP services and resources to clients from across Connecticut because we see a large amount of clients and individuals coming throughout the state. We see that clients do return syringes, that even if the rate is not exactly a one-to-one exchange, that clients do return syringes at about an 80% rate during that time period. We also see that storefront transactions do make up most of the transactions at the van in total, even between vending machines and such. We see about 73% of all transactions at the van, whether that's at the storefront, the vending machines, or in the van, do come from the storefront. Future opportunities, we can strengthen our messaging around needle return, and this is something that has happened lately in the face of these government shutdowns. We've really strengthened the messaging around needing these needles back and for clients to come back with these used needles. We also can potentially, but we also can potentially use some of the demographic data we have on the clients as well to better understand our local clientele. And then, so here are the main lessons learned through the internship. Sort of learned how a medical clinic operates on a daily basis and the various components that go into its function, how to engage with the local community to develop positive relationships with clients and ensure their needs are met, and then how to share information with other colleagues and peers across the local and statewide community. A lot of what I did during the summer was create some of these data visualizations that were able to be shared with the city of New Haven, with the state of Connecticut, to sort of support efforts throughout the that the van was interested in. And then also through this internship, I helped learn how to coordinate and implement brief informational initiatives for quality improvement. And then kind of just to wrap up here, through this summer internship, we were able to put together a poster here and attend the Quality Improvement and HIV Syndemic Conference in October up in Hartford. And I helped lead the development of the poster with Natalie and Rollo here as well, focused on our vending machine program. And our poster was successful. It received the recognition for best overall poster and most innovative idea. So this kind of drives home the point that these vending machines, in particular, are an area of interest throughout the state, and that sort of understanding them and understanding, while they're still very quite new in the area, understanding them at a better rate is beneficial for the state and for us as a local organization. And then here's just some of that poster. In the poster as well, we highlight that the service location for the vending machines also reach a sizable amount of clients that do not actually come into our stores. So we see here that about almost half of these people at the App Foundation that utilize our vending machines and don't actually come into our storefront. They use the services just from the vending machines. So we're really expanding the reach with these vending machines, which is a crucial facet of interest for the community healthcare van. And that's all I have. Thank you.
Thanks, Shawn. Great job. All right, Trace, why don't we turn it over to you?
All right. Well, let's thank you guys both. This is really amazing work and very comprehensive, and hopefully everybody was happy, both with your experience and the healthcare van's experience. So let's just open it up if anybody has some general questions or comments first. And if not, I have some leading kind of questions we could ask. But any comments either for Soha or Shawn?
I have a question for Soha. You mentioned that the sample size was smaller than you had anticipated. Can you share a little bit about what that outreach or recruitment strategy was, and then maybe what you consider some of the barriers to getting a higher sample for your project?
Yeah, thank you for your question. Yeah, so for me, initially when I looked at the data, I think I did mention this too. The data that I worked with, I was primarily tasked with data analysis of it. So I was not there for the recruitment part of it. It was done by a previous intern the year before, I believe maybe an undergraduate student. And I just worked on creating it. So when I saw that the data was roughly 70, I was pretty excited that that is a decent amount for the storefront. But when I got to cleaning it, not only was I removing like 510, it went from 72 to like 52. So that was like 20 drop. So what I would anticipate was a barrier was trying to find a motivation for someone to participate in the survey. We're asking them not only history, demographic questions, but we're also asking them about like, I think it was 24 items broken down by 6, 6, and 10. So this is kind of an investment for them because a lot of them are like, I'm late from my experience, are like, I'm late for the bus. I need to make this bus. I need to run here. Um, I think it would be really nice, like I mentioned, for a future plan to have a better incentive that aligns with what they're looking for. Maybe a $10 Dunkin' gift card, whatever is within our capabilities of providing them so that they can sit down and possibly take this survey for us. But yeah, hope that answers the question.
All right, I have a question that hopefully can combine both Soha and Shawn's projects. So, I think one of the things about some of these potential harm reduction activities is the stigma and the community level stigma that exists around harm reduction in general. And some of that relates to what people's beliefs are. Like, I think when you one-on-one explain harm reduction to people, it's an easy way to, like, I rarely have seen someone who is not convinced of harm reduction strategies when you kind of sit down and talk to them. But the question is, we can't sit down and talk to everybody, and there are beliefs, and then there are some manifestations of the harm reduction that I think adds to this, and some of that is things like the syringes. I remember Robert Heimer and I were at a community event, and Elliker, the mayor, came up to us and is like, "What do I do with I love these harm reduction programs, but like I get a lot of complaints about syringes everywhere, and what do we do about these syringes everywhere?" And so that's kind of some of what Shawn was talking about his program. And so, is there a way we can kind of do some of the common, we try to come up with common solutions, while having, a Negroni at this event, but, he was not satisfied with the solutions. I thought we had some good ones, but is there a way to kind of, show kind of, do things that will help show the larger community of the importance of the event, but also assuage them and put things in place to minimize kind of some of these easy points that people can point to that can kind of reduce the overall endorsement of some of these services. Does that make sense to you guys?
Yeah, I think that's a great point. I know one thing that sort of could be expanded upon in the city is that the C-click fix. So when people go out and they can like report the location of these syringes, um, right now it's sort of impossible for the staff to kind of go out proactively into the city at the frequency needed to actually like potentially clean up every syringe in the city. Um, so sort of having the community be able to report them and then kind of tell us where to go and then exactly what to do would be pretty beneficial to the community healthcare van.
Yeah, and I want to touch on what you mentioned earlier, where I know when you talk face to face with someone about harm reduction, most likely they would be swayed because everyone sees the importance of it, which is why I thought it was important. It was last minute where I decided I should incorporate things I did in social media to do harm reduction stuff. That's what I meant by social media. I know our social media is very new compared to, like, the staggering numbers that Shawn was mentioning with in-person activities. I think it has the potential to grow massively. One of my ideas I had early on this summer that I had written in my proposal was to basically have people that have had a detox basically and just come sometimes, and like I know when I would go on these like rides to give out services, there was a lot of mention about how these people sometimes do a detox and their life changes and they want to share that on a broader platform. We can provide that broader platform for them. And I've seen it happen. There's this in New Hampshire, a Instagram page with about like 50,000 followers. When we have people that talk about their life and how their interaction with substance abuse, those garner the most amount of views. Those garner the most amount of interactions, and they get shared on multi levels. So that is something we can do slowly and surely. So we don't have to do that individual constantly. We can have one person talk about their experiences with it. And that could resonate with many people because we don't know what aspect will resonate with someone. So, and it makes more sense to come from someone that's lived that lifestyle to be able to explain what it's truly like.
Thank you.
I have sort of a general question maybe for Natalie and Shawn and Soha, which is, I mean, Soha talked about working with student data from previous student placed there. So thinking about going forward, one of the things we've talked about is trying to have some more continuity from year to year with our student placement. So if you have some ideas for what that might look like, given probably if we're talking about summer interns, there's sort of a time lapse there, but in terms of continuity around projects or like passing the torch, that kind of stuff.
Yeah, I think one thing that could kind of be done on a yearly basis is for a summer intern to potentially put together sort of a yearly report, maybe on a fixed time period, to give to the community healthcare vans. So something they can kind of rely on receiving at the end of the summer that they could use to show various stakeholders at the local and state level that sort of like, here are the areas of focus that we're working on. Here are some improvement areas we want to target. So I think something like that could be kind of cyclical for interns to come in. And if there's already kind of a predefined like outline of what exactly to look for, maybe that could be something of interest. I'm not sure, Natalie, do you have any ideas?
Yeah, thank you both to Soha and Shawn for putting these presentations together and for all of your hard work over the summer. I will say, like, I don't think it was reflected in Shawn's presentation how many different databases he had to pull quality data from. Soha's was, also a little bit messy. So I think, Shawn spent a lot of time just cleaning data sets to get it to the point where he could look at things and combining them and trying to match from various sources where we're required to enter data. So I think in that sense, yeah, if we had sort of tacking on to what Soha did, like an annual patient satisfaction survey, which is how we added the stigma questions onto our satisfaction questions. There could be a way to have some ongoing outcomes that we look at each year that we could, kind of plug an intern into rather than sort of creating something every year. That might be a way to do it. Because I feel like they had to both sort of work on getting the data into usable things before they could even start. So maybe we could.
Yeah, hopefully, I mean, that would, given what they did, that would, yeah, as you're saying, might be less of a, every time it would be a little bit less of a, less of a,
Yeah.
yeah.
Yeah,
So,
we definitely have a lot of their coding now that we
right.
can put into place.
Well,
But
hopefully, I mean, did you guys, I mean, not to put them on the spot, but did you guys, I hope you guys felt, Natalie, you guys felt it was an experience that was helpful from your perspective.
yeah, we're using both of their data as well as Soha's social media work to inform the projects and initiatives that we have. As you mentioned, we have ongoing conversations with the city about the syringe litter. We have it's helpful to have Shawn's data and maps and whatever because they're asking us about how we plan to address these issues. So at least we're a little more informed in where the hot spots are. So yeah, I tried to work with them both to make it to things that we needed to help us with our services.
I would say, I think, not saying anything about our past experiences, but I think this is both in terms of the kind of complexity of what you guys did and the presentations. And hopefully the experiences this does seem to end, I think, with Jason's help with the health equity fellowships and kind of the guidance. And this was our most successful season yet, and the both presentations were very impressive. So thank you all for all of your work.
Great. Yeah, and thank you to Shawn and Soha. They were awesome.
Great.
All right, well, I think we are out of time. So thank you all for coming. Thank you guys for presenting, and great job.
Thanks, everybody.